Yes, we can start now. We can start now.
Good evening, respected doctors. On behalf of Palsons Derma Private Limited, the technical partner of this program, it is my privilege to warmly welcome all of you to this scientific masterclass. We are happy to introduce the Derma Masterclass series, an academic initiative comprising 25 webinar sessions designed to systematically cover the major chapters from the dermatology textbooks. Our objective is to provide a platform for academic enrichment through expert-led discussions, clinical insights, and recent advances. Helping us navigate today's discussion is Dr. H. Abhinita, Honorable General Secretary of Psychodermatology Association of India, PDAI, Professor of Dermatology, the Oxford Medical College Hospital and Research Center, Bangalore. Over to you, Dr. H. Abhinita. I would request you to introduce our speaker for tonight.
Thank you for your kind introduction. Good evening, everyone. On behalf of the Psychodermatology Association of India, it is my privilege to introduce our distinguished speaker, Dr. Koushik Lahiri, one of the India's most respected dermatologists and an internationally acclaimed academician. He is the honorary professor and senior consultant dermatologist at Apollo Multispeciality Hospitals, Kolkata. He is also the honorary medical director of Wisdom and currently the president of the Association Psychodermatology Association of India. He has over 200 plus publications, 9 books, and thousands of citations and numerous national and international awards in his kitty. Dr. Koushik Lahiri has also made exceptional contributions to dermatology, research, education, and psychodermatology as well. We are delighted to have him with us today, and I look forward to an enlightening and inspiring session. Over to you, sir.
Thank you, Abhinita. It's a really privilege for me to be here with you, and thank you, Palsons Derma, for being the real support behind this endeavor, the Derma Masterclass, and I'm very happy to be here today. So let me try to share my screen. Is it? Can I see everyone?
Not yet, sir.
Okay. Now, can you see?
Yes, it's coming.
Okay.
Perfect.
So it is full screen now, right? Okay.
Yes, yes. Yeah.
So thank you very much, Abhinita, for kind introduction. And without much ado, you have already read this series. So today, our topic of discussion for the next 50 minutes, about 45 to 50 minutes, will just overview of the psychodermatology, the mind-skin connection. As you all know, like this is a dermatology department of any hospital. You can see the psoriasis, like the posters are there, and all are checking their mobiles and looking at each other. All are concerned, but we are ignoring elephant in the room, and that is the mental health. Nobody is discussing, nobody is thinking about the mental health that they are suffering from. So that is the issue. Why mental health matters? Because the invisible suffering, whereas the visible disease, the patients came with their visible ailment on their body, but the invisible ailment we rarely discuss. So the hidden comorbidity of chronic Crohn's disease, we'll be surprised to know, because this is actually mainly for dermatologists, and some psychiatrists and psychologists friends are also attending today's webinar, or national webinar. So this is a huge study of 3,635 dermatology outpatient in 13 countries. And depression was identified in 10% of the patients and compared to 4.3% of the control. With suicidal ideation is about 12.7%. So what I told is like this. In general population, it has depression of 4.3%, but the depression among the dermatology patients are 10%. That is more than twice. And anxiety, if you compare 11 in the general population, in dermatology patients, they're 17.2%. And similarly, the suicidal ideation from 8 to 12%. So it is definitely the epidemiology of psychiatric morbidity is definitely much more than what we expected. So that is why mental health is important. So why dermatologists must care? Because the patient experience depression or anxiety, why they are coming to your clinic? More likely to demonstrate the poor treatment adherence and the frequent unscheduled consultation, reduced satisfaction. They are going out of your clinic again, coming back. Mental health, they're very anxious. So this adherence and treatment success depends on their quality of life, the mental health. So invisible burden of visible disease, we are actually trained to diagnose the visible disease. Like the patient is relatively limited skin involvement, they experience profound emotional suffering. I'll come into the details of it later on. We really discuss the psychological distress, the stigma, shame, isolation, and we are actually not sensitized about all these terms. The feeling of embarrassment, shame, fear, rejection, why the impaired self-esteem, why the patient is crying in front of you with a very trivial disease. Now, if we elaborate this little further, we can see the erythema, we can see the scaling, we can see the pigmentation with our naked eye. But no microscope, no dermatoscope can actually unearth the hidden distress, the shame, the anxiety, the relationship difficulties, the work impairments, and that is there under the surface, and that is just like a iceberg. So so that is why psychodermatology is relevant here, extremely relevant. That psychodermatology deals with the condition. It includes the primary psychiatric disorder, secondary psychiatric disorder, and psychophysiologic disorder. I'll come to the details about it much later. So the brain-screen axis, the bidirectional relationship from the biological basis of psychodermatology. We all know that when we were at the embryo form, the embryologic origin, the ectoderm, and the interconnected throughout the life, like you know about the neuroectoderm, and from there the pluripotent stem cell, from where both the dermatology, the skin, and also the nerve tissues they develop. So this is actually the scheme that when the brain is affected, the skin also is not happy, and when the skin is affected, brain definitely gets anxious, and that's why probably think of any medical college, any department of dermatology and psychiatry is always side by side. And sometimes the patient inflow from the dermatology department goes to psychiatry. Psychiatry patient comes to dermatology department. So this happens. This is a cartoon, but this is not exactly a comic cartoon. It is actually a serious condition where we have like an overlap from dermatology and psychiatry. The stigma, the invisible lesion. You cannot see stigma with a hand lens or even a dermatoscope, right? The staring, avoidance, discrimination, bullying, as an internalized stigma characterized by shame, reduced self-worth, and social withdrawal. So these experiences actually they lead the patient to our department. The persistent stigma correlates strongly with depression, anxiety, impaired quality of life, often more closely than the physician assesses these children. The physician is me myself, and I'm not actually trained in this part of the mental health. So depression in dermatology patient, just look at the eyes of this little girl, and she's an attractive, beautiful girl, but unfortunately, the melancholy, the sadness in her eyes, it is reflected, and very low mood, like anhedonia, fatigue. She is retracted from the whole classroom. The depression, it manifests with excessive concern of the disease progression, repeated consultation, and she is always anxious. She always tells her parents that it's not going that it's not going, ma'am. Please go to the doctor again. So the patient, and sometimes, Jackie kya hoga? So they don't go to the doctors. They just avoid going meeting the doctors. And when you are telling patient to look at you, the patient trying to hide the faces. So anxiety and the shame associated with it. So that makes the picture even worse. And anxiety, the chronic skin disease, is also huge thing. The social withdrawal. You know about our vitiligo patient. You know about our psoriasis patients. You know about our patients with mm, even the loss of eyebrow, even with the loss of the bald patches on the scalp, alopecia area. They also, the social withdrawal is terrific. The loneliness, depression, the reduced resilience. So dermatology should routinely inquire about the work performance relationship and the participation in social activity, the identification psychology, psychosocial environment, and the body image disturbance. And it's more important when we see the young adults or the teenagers. Yeah, it disrupts the body image through visible disfigurement and altered self-perception and fear of social judgment. And it may occur even in objectively mild disease. For example, the patient with psoriasis of only the hands. It's only the hands, the fingertips. But it's a mild, a small area of the body surface area. But the functional impairment would be greater when compared to a person with the same area of involvement, the less utilized area of the body. So that is what important, where exactly it matters. You know the Pareto principle? Pareto principle, where the 20% seems more than the 80%. So what I was discussing, just think about this. It's for anyone, a student, housekeeper, anyone in the family, or even farmers. Only this body part is involved, and this is a huge thing in his or her life, and can't even tolerate. And this is not even 5% of the total body surface area, but she cannot face the world. She's always like in a sense of guilt or shame or like a social withdrawal completely. So that is the issue. What is body dysmorphic? Is characterized by excessive preoccupation with the perceived defects, not what I was discussed there. And they're either absent or minimally noticeable to others. And if I say that the excessive looking at the mirror, camouflaging, and COVID has gone, but many of our patients are still coming with a mask because the pigmented post-inflammatory pigmentation after the acne or anything like any acne scar or chickenpox scars are there, but they are camouflaging. Repeated consultation, so they're going back again, coming back on the next day. So that's what I bhul gaya tha. And I don't think I have shown you this particular mark and some unrealistic expectation that they think that the flawless, perfect appearance, the Korean glass skin, the so-called, what is not exactly possible, but they always think that this was needed. And if I dare to say that the whole of the aesthetic practice or so-called cosmetic practice, but not always by the dermatologist, I must say, that is actually based on this body dysmorphic disorder. Because these are not always any disease. They're coming with some very trivial thing which is will go away with some few days or months. But as doctor, you should tell that, "Dekho beta, kuch nahi hua." It will go. But we are not doing that. We are telling that, yes, I'll be able to do this with this lasers and peels and everything. So go to the front desk and they will give the package. That is where the gray line between the real scientific medicine and ethics. But anyway, that is outside the scope of my talk today. So quality of life, the measuring what matters, we know about the quality of life. But this particular slide, I love to show to our non-dermatologist friend, but here today the dermatologists are mainly here. And why it is important, because score 1 to 11, the arthritis is 6, 8 is chronic lung disease, 11 is congestive heart failure. This is actually quality of life. 9 is diabetes and psoriasis is 10. So psoriasis, a patient for psoriasis, the life actually becomes hell. And the impact of psoriasis on mind, look at this. Impact of mental component, 11 is depression, 10 is chronic lung disease, 5 is chronic heart failure, psoriasis is 9. So it is actually, it affects the patient's mental health more than that of chronic heart failure. So that is significant. And 78% of the psoriatics, they indicate the negative impact on their life quality. When should dermatologists intervene? Nowhere it's written in our textbook. When the 3Ds, distress, dysfunction, and danger. So what is distress? Distress refers to the significant emotional suffering. Patient is emotionally very, very devastated. What is dysfunction? That includes the impairment of occupational, social, or interpersonal function. What is danger? It encompasses the suicidal ideation, self-harm, severe psychiatric symptoms, or inability to care for oneself. The recognition of these thresholds that enables timely intervention and appropriate response. Whatever I'm telling, you can see it's referenced actually. So the traffic light interventional model is also being used by psychologists and psychiatrists in the green zone. Exhibit distress, can usually manage by reassurance. Amber zone, moderate symptoms, the impaired coping, declining of life, the benefit from counseling, structured psychological support, closer monitoring. But the red zone, severe depression, suicidal ideation, psychosis, severe body dysmorphic disorder, you need to take the help of a mental health expert. So psychoeducation, what is that? Actually, psychoeducation, first and most powerful intervention. You know what is exactly happening as a dermatologist. You know, understand the individual, make sense of the information and relate to their own experience and goals. Once you understand that, well, this is a condition of not only the skin, the psychiatric part is also involved. Then you are empowered. You are actually empowered to treat the patient, and the patient is also empowered. The building of confidence, the skills and self-efficacy, that helps. The adherence, patient is also adherent to the treatment. In most of the patient with psoriasis or even vitiligo, say a patient of the acquired vitiligo, the adherence is very important. And also a patient with the androgenic alopecia, you tell the patient to be regular in their treatment, the patient may not come. So when you understand the patient's understanding, when you understand the patient's expectation, you can also explain, and the improved outcome is also expected. Do you think that the suicide risk in dermatology? Yes, yes, and we have many studies on it, and this is a very, very famous article published in Journal of European Academy of Dermatology, and in 2019, you can see it was a systematic review and meta-analysis of 31 studies. It's a huge article, an increased risk compared to the individual without skin disease. Suicidal ideation is almost 1.5 times more. Suicide attempts is again 1.62 times more. And suicide completion, you can't believe, 2.2 times more than others. So dermatological condition associated with higher suicide risk. Yes, the gastric right, psoriasis is number one, atopic dermatitis, acne. When we worked with Indian Acne Alliance way back in 2008, yes, there was the chapter on this, and we mentioned about the suicidal ideation in that. The alopecia areata, hidradenitis suppurativa, vitiligo, chronic urticaria, cutaneous lupus erythematosus is actually significant. When the risk is higher, the visible lesions, the stigma, the judgment, the embarrassment, social withdrawal, bullying, discrimination, everything happens. As a dermatologist, what we can do? You can screen, ask about mood. We never ask about mood. We never ask about the suicidal thought. Assess, validated, this is very difficult in a busy OPD. Support, the provide empathic communication and reassurance. Collaborate with the mental health professional when needed, and follow up with a mental well-being and alongside skin disease treatment. And so this is very, very important. And I love to show this photo. It's very, very sad, and whenever I think about this story, I felt like very bad about this particular boy. His name is Azad. Actually, his name is not Azad, but I always tell his name is Azad. He's a grown-up boy about mid-20s and studying in the completed his master's, was doing his PhD, and was there in the Big Apple, that is New York. You know about the New York, and he was waiting for his like a your green card, and for an Indian those days, even now, getting a green card is a big issue, very very big deal. So all was needed to do the biometric. We all know about this biometric. Now it was impossible for this young boy to finish biometric. He received 3 appointments, and getting an appointment in US for green card biometrics is not easy. It's not easy at all. There's a huge number of patients, like a person's waiting. And at the same time, actually, the globe was also being engulfed with the deadly coronavirus, the global pandemic, and all the flights were cancelled there. It's actually from India, so I'm not giving the details, but at the same time, the Big Apple in New York was covered with snow, white snow completely. Azad was found to dead in his apartment. He committed suicide, and that is why psychiatry is important. That is why mental health is important. That is why dermatology is important. He committed suicide because of a dermatologist disease. So suicide risk in dermatology, you just look at the suicidal behavior, suicidal ideation, and the starting from the psychological distress to anxiety to depression to hopelessness to suicidal ideation and the suicidal behavior. So these are very much needed for a dermatologist to understand. So what is chronic illness? Why actually we need to know why chronic is this more than 3 months. For the CDC, it is more than 1 year. 6 out of 10 Americans have one chronic disease. In India also, chronic diseases are more. And unfortunately, not all the dermatological disorder will fit into the legal definition, because it is chronically ill means considered eligible to certain services and care. But dermatological illness may not always be there. But you think about the dermatological disease, they are chronic. And the challenges of chronic diseases are many, starting from the financial crisis to like a chronic illness, managing mental health, everything is there. Multiple specialist treatment, and who has the time to go to different doctors. And all the dermatologists, the psoriasis, atopic dermatitis, blistering diseases, and vitiligo, keloid, hidradenitis suppurativa, leprosy, acne, hair loss, everything is actually chronic. The business cycle of chronic skin disease is there in dermatology. So it's known for non-dermatologists that dermatologic diseases are actually chronic. So the patient also understand, and their mood is affected. They have difficulties with self-esteem, they feel depressed, and they always stay indoors. Effect of skin disease, psychosocial, physical. Physically, we know the discomfort and limitation, but the psychosocial part, cognitive, social, emotional, and out of emotional, the depression, fear, embarrassment, anger, everything is there. And other than this, if I just look at this, the breaking bad news to incredible disease, you're not actually a neurosurgeon. So you don't have to face cases where a 3-year-old boy is having some incurable brain tumor, and you need to tell this to the parents. You don't face situation, but you face situation of a boy, a 5-year-old with vitiligo, and parents are there, the whole family is there. That's how it ho jayega na. So that is the moment you don't know how to communicate with these cases. As a young doctor, sometimes it's very, very difficult. So empathy, what is empathy? Empathy is not sympathy. It's the 3 components: the cognitive focus, including in the patient's perspective, an affective focus, experiencing the surrogate feelings, and an action focus. explicit acknowledgement of the emotions, and allowing the patient to modulate the patient physician's understanding. What is NAS? That's very interesting. Nurses make the best efforts. The emotion that the patient seems to be experiencing must use him upset. I can see that you are worried. So this is actually acknowledging the patient's, respecting the patient's like emotions and what they are suffering from. Understand. Given what you have gone through, I can see that you are feeling this way. How many people feel the same way you're feeling the situation is very understandable. And respect, this is important. Indian doctors, we really have time to do all this, but globally this is followed. I can see that you have made a lot of effort to remember and to take care of the skin. Congratulations. And support. If your problem gets worse, please be sure to call us. So these four things, nurse, is important. Making bad news with the how like our junior colleagues always said, how you tell the patients, all the patients' parents that this is psoriasis, इसका भी ठीक होने वाला नहीं है. It will not be cured. Or this is actually acral vitiligo. It's not very easy to treat. So declaring that incurable disease is not an easy task, actually, for a young physicians. So when they ask, is it curable? What you should tell? You should tell that if you think that cure is curing of the lesions, yes, it's possible. But if you think cure means it will not come again, it's difficult to say. And so by saying that, you should not tell anything which is actually non-scientific. And storytelling. Our old-time doctors, LMF doctors, MB doctors, senior physicians, they were lovely in storytelling. We forgot the art of storytelling. The patient-doctor relationship builds on the storytelling. In Indian situation, we always say the patient is very angry. There are some like a stone throwing or like hitting the doctors in the government medical colleges, or the patient is extremely angry and they're shouting at your front desk like a personnel. It's a reaction of grief, dissatisfaction, anxiety, or some unrelated event. Actually, this may not be for your treatment. The patient is yet to meet you, but actually, the patient is react to. What we do? We actually react to the same emotion. Anger is treated with anger, and that is not correct. You are the first victim of your anger. So this is very important. And the patient is actually, the angry patient is actually most frightened patient. What are the symptoms might be driving the patient's anger? It may not be related to the skin disorder. Maybe someone in the family is ill. Maybe the mother or father or the husband, wife or a child is not well in the family. So there is some anxiety working. That's why the patient is very angry, waiting here for long. We never discuss about it. Responding to the fear component of anger is produce the desired effect of. You just call the patient, hold her hands. What exactly happened to you, madam? Why are you so angry? Then you'll realize nothing to do with your treatment actually. So this is important. Patient disappointment, it's actually an art to deal with. How to handle. So I wish things were different. I wish we had a better treatment for your disease. A patient is coming to you again and again. And even a patient with a hirsutism is coming to your clinic. That's not how many visits I'll have to come. How many like sessions of laser are needed. So, but don't ever tell that I'm sorry. Because when you're telling this apology or expression of pity, so that's not the correct thing. Because you are the doctor, research studies are important for complete transparency. You discuss everything about this with the patient. It doesn't matter what the patient's understanding, and it doesn't matter whether the patient is literate or not, but tell everything in details if you have time, and otherwise there should not be any opacity, because ultimately it's the patient's body and patient's mind. The setting patient's expectation is also important. Not it's always you should under promise and over deliver, right? So how to deal with this? Listen first, because we doctors you forgot to listen to the patient's story, and when the patient is finished, then you use your soft skills. So enhancing the interpersonal skills as a doctor, the delusion of grandiose that you are on an elevated pedestal for own health. So you are actually on the same platform. Today, you are the doctor, the person sitting on the opposite side, maybe a police commissioner, maybe an income tax person, or the lawyer, or another doctor, or a PhD scholar, or even a farmer, or a mine worker, anyone who is also a citizen. So have some respect for the patient, and no one actually works on this. But in some areas, in the global liberal arts, the soft skill are also developed in doctors. I hope in someday in India also soft skill will be included in medical curricula. So we have this chapter on empathy and ethos and clinical practice. So what are the types of psychodermatological conditions? This is the second part of my lecture. The first part I have finished. The psychodermatology second part is the primary psychiatric disorder, secondary psychiatric disorder, and psychosomatic disorder. So what exactly is the primary psychiatric disorder? Very easy to understand. Primary psychiatric is basically a psychiatric disorder. The patient is actually psychiatrically troubled, and that is being manifested with various skin changes like trichotillomania, the factitial dermatitis, neurotic excoriation, delusion of parasitosis. This patient is actually having psychiatric problem. Secondary psychiatric disorder, the patient is basically a dermatologic patient, but a psych is involved. I told you the brain and skin interface. Suppose someone is having vitiligo on the face or psoriasis, so they are anxious, they lost their life self-confidence, they're depressed, social phobia. So that is secondary psychiatric disorder. But psychosomatic disorder, it refers to the skin disorder that's not directly caused by psychological factors, but a reactive, and it's exacerbated or worsened by the skin. How to classify? Look at this. This is a unique like a slide. This is primary psychiatric disorder. This is the secondary psychiatric disorder, and the psychophysiological disorders and cutaneous sensory disorder come everything one by one. Primary psychiatric disorder can be divided into delusional disorder, self-mutilating disorder. I'll show you some pictures why these are called self-mutilating, and obsessive compulsive disorder, the tendencies. For delusional disorder, we have hypochondriac behavior and body dysmorphic disorders. From the obsessive compulsive disorder, obsessional thoughts, and impulsive or compulsive acts. Well, the secondary psychiatric disorder, we know about the pathology. They develop the psychological symptoms like alopecia, vitiligo, leprosy, acne, and many diseases that can have psychiatric like a part. Psychosocial, psychophysiological disorder, and actually exacerbated, but precipitated by stress, lichen simplex, Crohn's, and chronic urticaria, atopic dermatitis, and psoriasis, the alopecia areata, dyshydrotic eczema. So these are actually exacerbated or precipitated by stress. We all know that. Seborrheic dermatitis, acne vulgaris, lichen planus, psychogenic purpura, rosacea, urticaria. So the more you understand about the psychodermatological disorder, you understand this is a completely separate universe, another planet altogether, and which we completely ignore in our day-to-day practice as dermatologists and even as psychiatrists. So cutaneous sensory disorder, that's interesting, the intolerable cutaneous. So when the patient is coming, the burning, stinging, itching, crawling, or biting, nothing is there on the skin, the invisible dermatosis. No skin disease, like a systemic abnormalities is there. There may or may not be an associated psychiatric disturbance. The patient is always anxious. That's what kuch nahi ho raha hai. And they are anxious, they are depressed. The cutaneous sensory disorder, chronic pain syndrome in medical clinic, and also what is delusional disorder that comes under the primary psychiatric disorder. So dermatosis is a result of delusional illness and hallucinations. So the patient's great subjective certainty. Patient is absolutely sure. So unshakability of the patient's belief. And don't try to tell that, no, you are telling absolutely wrong. Whatever I'm telling is correct. Do not ever try to do that. And presentation of delusional disease in dermatology. You remember parasitosis? we get it regularly, the patient is absolutely confident that there is some parasite, something crawling. So delusion infestation, body odor delusion, olfactory hallucination, bromohydrosis, and we get it regularly. The patient can smell something which you can't, and sometimes it's shared in the family. And I have seen a patient with like a bromhidrosis, shared bromhidrosis. Actually, there is no smell, but even if office colleagues can smell that. So hypochondriacal delusion, syphilis delusion, AIDS delusion, and body dysmorphic delusion, delusional dysmorphophobia, and delusional parasitosis. You know about the delusional parasite, the most frequent delusional disorder. And it's a skin-related disorder, assumption of parasitic infestation, and this kind of thing is very common. Patient comes with the parasites, insects in the matchbox. You have seen that this is actually nothing but a dead skin and some like a excoriated part of the skin on the back. So the body odor delusion, bromhidrosis. We cannot go very near to this person. Subjective unpleasant odor resulting in psychological or psychosocial. So, bromhidrosis, subjective colored sweat is all we encounter. And what about body dysmorphic disorders? My favorite topic there is dermatological non-disease. Body dysmorphic delusions and excessive preoccupation with uncorrectable imagined deficiency or disfigurement or outward appearance which takes the delusional proportion. And sometimes it is written by Cottrell wrote that I know of no more difficult patient to treat than those with body dysmorphic disorder. And body dysmorphic disorder, these days, it has reached another level. I'll show you why. Presumed hair loss. The patient comes to you and they show that's how I have lost this hair, not in one day, but in 2 months. So this is normal to lose hair in 2 months, but for patient, it seems it is huge actually. And the conditions associated with dysmorphia. What is this? This is a geographic term. It's a normal thing. And the patient thinks something is very, very wrong there. And this is polypenal papules. Again, condition associated with dysmorphia. Patient is not happy. And today, the social media in last 10 years, the chant, the new mirror on the wall, every time is trying to tell, mirror, mirror on the wall, tell me who's the most beautiful of all. And the TikTok, the Instagram, the YouTube, the promoters and perpetuator of beauty ideals, the fair skin, flawless complexion, Korean glass skin, filters, the editing tools, whatever they look like, it doesn't matter. The way they want to show it to the whole world, that is most important. Beauty is increasingly used to define the identity. So there are some wonderful articles on this topic, and so desire to improve self-esteem and social approval, and that is creating a huge thing on the human behavior in total. Young women, adolescent, LGBTQ communities are particularly vulnerable due to the highlighted pressure of appearance conformity. So this is very important, and I dare say that you know about my inclination in working with this topical steroid abuse. Why the patient uses topical steroid on face as a cosmetic cream? Why? To get fair, and that is the main thing why the TSDF of topical steroid dependent face happens. The acne cosmetica, contact dermatitis, post-inflammatory hyperpigmentation, all actually a part of this TSDF. So body dysmorphic disorder and beauty products, they characterized by obsessive focus on the perceived defects. 10% of the cosmetic dermatology patients are suffering from BDD. So that is extremely important, and that is actually that's published data. The beauty product dependency may mask deeper psychiatric needs, and some psychodermatosis from cosmeticals, the fairness cream, the topical steroid, the perioral dermatitis, steroid rosacea. Now everything is under this topical steroid damaged or dependent phase, TSDF. This is an entity of cutaneous pharmacodependency. You all know about PSDF. So the general population of the BDD prevalence rate is 2.4% in patients who are having the 7 to 15% of patients taking cosmetic procedures. They suffer from body dysmorphia. They are the main patients or clients for the aesthetic practitioners. Understanding the body dysmorphic disorder prevalence in general population is 2%, and in cosmetic procedure seekers is 7 to 15%. So 2% and 15% is almost a 800% jump. So obsessive compulsive disorder tendency, primary psychiatric disorder is under primary hypochondria. So they think they have some infection or neoplasia. Dysmorphophobia, the body dysmorphic disorder, right? What I was discussing. Or there are some interesting phobias, the candida phobia, AIDS phobia, venereal phobia. We get it regularly. Syphilis phobia, Borrelia phobia, parasitophobia is not that common. Parasitophobia should be differentiated from actual your patient who thinks that he has a crawling of insect on his body, and neoplasia or the carcinophobia. The melanoma phobia is not in our country, but they have various kinds of phobia. Compulsive acts, dermatitis para-artifacta syndrome. And you know about the skin picking. My last patient tonight was a patient of that epidermophilomania or neurotic excoriation, and all over the body, the neurotic excoriations in a 19-year-old girl. Acne excori, and they always doing this. Pseudoknuckles, cheilitis factitia, and integument, the onychophagia, onychochilomania, onychotinomania, trichotillomania, trichotillomania. Do you know the difference about it? I'll share what I came to know about. So this is dermatitis para-artifacta syndrome, and very interesting cases actually. You know about this gentleman? He had this. This is not his hand, definitely, but dermatitis para-artifacta, always nail biting, always doing this, and that can lead to this. This is not actually onychomycosis. This is due to the DPS. Trichotillomania. We know the patient is pulling their hair. But do you know about the other the three presentations? The long hair, unremarkable, not affected, normal hair. The missing hair, recent alopecia due to pulling. And the zone 3 is regrowth of hair, short and less regular. We all get these three zones. Now we know about the trichotillomania, right? So the person pulls his hair, while psychiatry had become compulsivity to that direction. So dermatology and psychiatry, the classical trichotillomania. So the most common underlying psychopathology is obsessive compulsive disorder. Here, the obsession and compulsion both are there. Other possible factors are reaction to stress. The patient, there may be usually young boy or girl, and there may be family fight, parents are fighting, or there is someone is bullying in the family, and that anxiety or depression or stress. This mental, they are actually doing this. They are trying to dug out the hair, and with a delusional belief that something in the root that needs to be dug out. And sometimes they are doing it unconsciously. They are not exactly conscious, but they get a pleasure when they are doing it. That is important. And you know about the trichotillomania, right? So this is the classical photos of trichotillomania. But do you know what trichomalacia? It's a rare condition with the pathologic examination is diagnosed. The hair root undergoes the unique change called trichomalacia, which occurs in patients with trichotillomania only. You know about the trichotillomania? It's so when the terminal hair ends into mechanical abrasive traumatization. It can happen with combing also. It can happen with like a pulling. What is trichotillomania? Trichotillomania is a cutting, and the usually young girls and boys they cut off their hair and classify the artifact or malingering. And what is trichotillomania? It's a self-inflicted hair loss. Physical damage is by rubbing or scratching of the scalp, resulting in pseudo-alopecia. So, other than trichotillomania, you have trichotillomania, and trichotillomania. So, there are some other rare forms like trichotillophagia, trichobezoar, onychotillomania, onychophagia. glossophilamania. So treat trichobezoar. When we were like undergraduate students in surgery, you have seen the trichobezoar. I have seen patients of trichobezoar and coming out of the intestine. For years together, they have taken this sperm out. So they are the clinical criteria of this self-mutilating disorder, wrist slashing or delicate self cutting. Now we regularly do the lasers and we give some ointments and we know how to drill and we know how difficult it is to treat Munchausen syndromes, and you can see that is actually they are doing it regularly. And malingering is constriction dermatitis, is architecture syndrome of the left shoulder or upper left hand to establish contact with the doctor. Because that is the secondary profit. We as dermatologists, we are unaware of this. The girl develops some affinity towards the doctor. So he has to come to the doctor more often. So that's why he needs to create the disease. So that is why he is doing this. And look at this person who is actually a construction worker. So what he did, he immersed his hand in the liquid cement without protective gloves, and that numerous periods of disability certified by various doctors, and the patient had desire for disability. So there are many patients who that's a थोड़ा लिख देना 10 दिन के लिए 10 दिन के लिए थोड़ा medical unfit कर देना. So that is the same patient and the desire for disability. So these all are actually dermatitis artifacta, and these are horrible photos of dermatitis artifacta on the face. And so these all are. And this particular photo was shared by Dr. Parimalata, and she is an excellent teacher and a polymath. And you can see this particular person, and rectilinear biliary lesion mainly over the accessible areas of the body. And you cannot match this with any particular disease, right? And but here you can see what is this called? The non-accessible in the back is spared. This particular rhomboidal area is spared, and because her hand cannot reach that area. And this is also dermatitis artifacta, and this was also shared by Dr. S. Premalata. And bizarre pattern lesion of the accessible part, or the aluminium part. But this area of the same gentleman is spared. That is inaccessible area. So as dermatologist, you can understand this is actually dermatitis artifacta. This is a very interesting case. An 11-year-old boy, cheerful boy, excoriation, crusted lesion of the face and limbs, and the whole department, like a family, was very, very unhappy. Why this is happening? Kaise ho ja raha hai every day? And the lesions appear spontaneously, not disturbed by the pain or burning sensation, but it is there all over. So it's there for 4 months. On examination, multiple crusted lesions in the linear fascia of the limbs and face, more on the left forearm and below knee. So that means with the right hand, but it's very difficult to make them understand. So diagnosis was done, but the patient's parents will not believe it. They felt offended and they wanted discharge from the hospital. Now what was done, the boy was meant to sit in the OPD in the full day in the corner and observe with the hidden camera. And we just see what happens. He was clearly seen scratching himself in the forearm. And the video of act of scratching himself without knowing is shown to the parents. And then they were convinced about the diagnosis. So this was an interesting case. I clicked this photo in 2005, 21 years back. This person visited from peelers to pores everywhere. And this particular entity was not cleared. When I asked, 1 year back, he had an eye operation. After that, he never washed his eyes. And this crust developed on the eye because he never actually cleared this, neglected that area. So I reported this case, and within 5 minutes, it was cleared with just saline water and spirit. So emotional somatocyclic disorders are there, and comorbidities in psychosomatic dermatology, depression, anxiety, compulsive disorder, stress, and dissociative disorder. So now skin disease frequently associated with psychiatric disorder. You know about all this. And the dissociative disorders, dissociative disorder may be present artifacts urticaria, acute pruritus, aesthetic skin areas, severe allergy symptom, when to refer to a psychiatrist. If you tell the patients next door, I have a very good psychiatrist, the next department is psychiatrist. No, I'm not a mad, I'm not like a crazy guy. So why are you supposed to sending this to a psychiatrist to how to treat these patients? And you can also write some medicines which can help this patient. So psychodermatopharmacotherapy, mental ka dawa de diya, right? So the medicine, shabare ye to mental ka dawa de diya aapko. So when you prescribe doxepin or nortriptyline, so I still use a lot. And the chemist shop will that saab ne to mental ka dawa de diya. One of the mental ka dawa, antidepressant, you can definitely you can write you can in dermatitis artifacta, you can write SSRI, you can write neurotic excoriation. As dermatologist, doxepin is a tricyclic antidepressant, very strong antipruritic, antihistaminic effect. You can definitely write doxepin. And in delusional psychodermatological disorder and in behavioral disorder, the haloperidol and pimoside, clozapine, olanzapine, risperidone, quetiapine, and these are all actually used these days in simply psychiatric disorder. That is actually your domain as dermatologist. Treat the dermatological entity effectively and give some time to the patient. This day, this is extremely important. Discuss about the disease and the therapeutic options. Take the help of a psychiatrist when necessary. Now, the psychiatric side effects of dermatological therapy. We all know that when you give steroid, it can have mania or even hypomania. The patient gets elevated. And it needs to decrease when you're withdrawing and the patient is again going back to depression. So isotretinoin, the depression, suicidal thoughts is actually documented. Not a single study has been reported from India, probably due to the family support. So other than this dermatological side effect of psychopharmacotherapy, we all know about this lithium. It can actually increase the psoriasis and aggravates some the conditions, acne. And we know about the antipsychotic chlorpromazine at urticaria can happen, and also some other condition, other like a benzodiazepines, it can have photosensitivity. Antidepressant like hair loss, photosensitivity, right? Cyclic antidepressant can cause dry mouth, eyes, and anticholinergic effect. Other than this, anticonvulsant, carbamazepine, the main medicine is just, and who doesn't know? Any dermatologist will tell that you have suffered from, the patient with SJS or 10, you know about the 1 to 5% is minor form is just, and overlapping is just in between 10 to 30%, and more than 30% is actually toxic epidermal necrolysis. Mortality is still about 30%. The stages of erythema multiforme, you need to be very, very careful about this. So these are all side effects of psychiatric medicine on skin, Steven-Johnson syndrome, and toxic epidermal necrolysis. We hope nobody of us, none of us who are today witnessing this will get this kind of patient. So to conclude, psychodermatologic disorders are actually conditions involving interaction between the mind and the skin. And they fall into three major categories: the psychosomatic, the primary psychiatric disorder, and secondary psychiatric disorder. About 30% of the dermatologic patients have psychiatric comorbidities, and the treatment of psychodermatological disease should be carried out through liaisotherapy. We are coming more and more conscious about the multidisciplinary approach: family physician, dermatologist, psychiatrist, and psychologist. Liaison with the dermatologist, psychiatrist, psychologist are need of the hour in bigger hospital, teaching hospital, that is quite possible. And to contribute, it's very important to educate dermatologists with the diagnostic procedure and therapy of psychiatric disorder, and also the combined biopsychosocial approach is essential for effective evaluation and treatment of dermatological disease and psychiatric comorbidity. And it's equally important to sensitize the psychiatrist about the different psychodermatological disorder. And majority of psychodermatological disorder can be treated with cognitive behavioral psychotherapy and psychotherapeutic stress and anxiety management techniques and psychotropic drugs. Before I finish, I have an announcement to make. On 5th and 6th of September this year, in the City of Joy in Kolkata, we are hosting the third biennial conference, SciDermCon of Psychodermatology Association of India, which is actually accredited by the South Asian Association of Psychodermatologists. So you all are welcome there, and you go Google and SciDermCon, and you'll get all the details. You can take a screenshot of this, you take a photo of this, and very easy to be a delegate. This is scan this, and you can easily be a delegate. And the whole program is online. More than 8 weeks before it is completely online, and it will definitely be a part of us. Thank you for your kind attention for the last 55 minutes. Thank you very much.
Hello.
Yes.
So thank you, sir. If you are having any queries, our respected delegates, please, write in the chat box.
But I'd love you to come to Kolkata to attend our conference, to learn about the intricacies of psychodermatology, which you can actually apply every day in our day-to-day clinic practice.
Thank you so much, sir. As we
Thank
come
you.
to the end of this enriching academic session, it is my privilege to propose the vote of thanks. On behalf of Palsons Derma, the technical partner of this program, I extend our heartfelt gratitude to Dr. Koushik Lahiri for sharing such valuable insights and practical clinical experience. Your enlightening presentation, backed by your vast experience and expertise, has undoubtedly enhanced our understanding of the subject and will greatly benefit everyone in their clinical practice. I would also like to sincerely thank all the respected doctors and postgraduate students who joined us today. Your active participation, thoughtful questions, and enthusiasm made this session truly interactive and meaningful. We hope today's session has been academically rewarding, and we look forward to your continued participation in our upcoming masterclass series. The next topic of Derma Masterclass is update on cutaneous clues to systemic disease. Speaker, Dr. Ram Gulati, and scheduled on 31st July 2026, Friday, 8:30 p.m. onwards. Once again, thank you, Doctor, and thank you to all our esteemed participants for being with us today. Have a wonderful evening, stay safe, and see you at our next session of Derma Masterclass. Thank you. Good night.
Good night. Good night, everyone. I've had many delegates from outside India as well. We can see some friends from Nepal, from Bangladesh. Thank you, everyone, for attending this. I can see Mahmoud, I can see Dr. Nupane. Thank you very much. We'll meet again here in Kolkata. Thank you very much. And thank you, Palsons Derma, for this wonderful arrangement. It's a flawless, absolutely flawless. And on behalf of the Psychodermatology Association, my heartfelt thanks to you all. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir.